Assalamu alaikum. Thank you, Mr. Chairperson. Thank you, Mr. Chairperson. أشكر اللجنة المنظمة لدعوتي للويدا. يعني طبعا يعني this is a topic for our vision to the future. على عكس الواقع يعني اللي موجود, but hoping إن ده يبقى إن شاء الله في المستقبل القريب يعني. Okay, we are talking about diabetes. It's a significant public health concern worldwide, and it's estimated to be the 7th leading cause of death. It's well known that a large population of these diabetics do not achieve their individual glycemic goals to the low adherence of therapy and to lack of awareness and consequences of uncontrolled diabetes سواء في الموربيديتي أو في المورتاليتي. حضراتكم acquainted بالفيجر دوت إن في عندنا rising numbers of diabetics worldwide وخصوصا في المينا region. Then what about the chronic care of a chronic disease? There is what's known as a chronic model for the treatment of diabetes وبعض chronic diseases, and this chronic model, it emphasizes the person-centered team care. يبقى في team مسؤول عن patient integrated. This team will be integrated long-term treatment, approaching to diabetes morbidities and all the time. The chronic care model involved many يعني subjects موجودين. أنا عندي community أنا عندي health system وكلهم في الآخر they will improve the outcome of my diabetic patients. Element of the chronic care, the delivery system team. This is a team consists of the dietitian, the endocrinologist surely, the pharmacist, and then all the team, they are collaborating for the patient health, the case of diabetes, what about his target, how can he care of himself, and then the decision support to the doctors. لازم ال doctors, primary care physicians, they must be updated for the diabetes care, clinical information systems, community and health system. However, then my diabetic patients will have all these, the health team taking care of him. However, this does not happen in reality. And that's why in real life, there's a gap between the real life and ideal practice. And then what's missing? A large population of diabetics do not have access to the specialist care in underdeserved area. Despite the progress of the available therapies, the patient still does not have, they cannot do their management plan, and the patient engagement in treatment plan is not present. The continuous glucose monitoring data management is not present. School-based diabetes for young youth and type 1 diabetics, behavior therapy for people with diabetes and their families. This could not be done by the chronic model. And then here comes what's known as telemedicine and telehealth. What's telemedicine? It's the use of telecommunication and information technologies in order to provide a clinical health care at a distance. It helps eliminating the distant barrier and improve the access to the medical health services. How can we do it? Communication service might be two-way videos, email, texting, smartphones, tablets, wireless monitoring. And thus, what's the importance of the telehealth here? It provides the specialty care that is convenient for the patient. It offers the vital support for the primary care physicians. It's part of it is that educational programs for them, and it will help decrease the cost of the care to improve the patient's outcome. It supports the population health in underdeserved area and provide interactive distant education for the providers to improve the quality care. And then the telehealth, under it, the taxonomy of the telehealth, there is teleeducation, telemedicine, and patient portal. The telemedicine, there is an interactive patient care, a remote patient monitoring, storing of the patient information. Development of telehealth in the diabetes, maybe about 20 years ago, but however, in 2016, there was a pilot study in the United States and Australia regarding type 1 diabetes. They're having a program for these young diabetics. Regarding the team, I will explain it afterwards. They were discussing the control of the blood glucose with different team regarding using the teletechnology. However, and also at academic centers in the USA, the healthcare outreach programs, mainly the program was for the primary care providers with how the primary care provider can contact the diabetic specialist for remote consultation systems. In 2018, the telemedicine requirement to build environment in the hospitals, hospital guidelines and outpatient guidelines for these telehealth, the requirements included the size of the space, the privacy in the room in the hospital, the lighting, the interior surface, the identification and the storage equipment. 2019, and a consensus endorsed by the American Diabetes Association and Advanced Technologies and Treatment of Diabetes defined new strategies for assessment of the glycemic controls in the telemedicine system. Measure the blood glucose, transmission of the data to be analyzed, and then remotely to the endocrinologist who will make the decision, and surely it will improve the outcome. How can be transmitted? Time interactive services. Telehealth required the virtual visits by the patient. The visits will be regarding the telemedicine. It will provide the opportunity for the community. How can the patient connect with the doctor at any time? Access to the medical records for the doctors, remote monitoring, online education for the patients, for the healthcare providers, and then tracking of the patients. What is the benefit of the telemedicine? Lifestyle modification. The message used including regular phones, video calls, virtual education sessions, and virtual physical exercise sessions. The meta-analysis of different studies using these modalities showed that the effect lasting between 3 and 12 months employed telemedicine lifestyle modification. A1C was reduced by 0.3% and weight was reduced by 0.6 kilograms. The glycemic control, users assess their current glycemic control, adjust the therapy, using the continuous glucose monitoring reports. And then also the smart pens, the device automatically recording the amount, timing of insulin application, wireless transmitted information to the mobile application can help a user to keep track of the previously administered insulin dose, administration time, collecting data to be transferred for healthcare provider to improve the outcome. And then also decision support system for insulin therapy, outpatient setting supporting the patient virtually, especially for vulnerable people who cannot reach the doctors, elderly mainly. And then also the tele-diabetology in diabetic care, food monitoring of diabetic foot ulcers by self-performing diabetic foot temperature assessment. The proposed system consists of a thermal camera connected to a smartphone, which used to acquire the thermal image. This image, as shown here, the red light, the red color, if the temperature is more than 2.2 degrees Celsius, representing the temperature difference, this can indicate the possible development of an ulcer. Acquiring the proper, this patient will be referred for physical examination, not only virtual, and also the advantage in diabetic retinopathy, a wide variety of simple retinal cameras, which is used by the primary care physician, does not require Medretic, and then the image will be transmitted to the ophthalmologist for further management. Studies of the telemedicine also, every innovation, it must be measured. Everything must be measurable. And there's different studies done in the last 15 years, published different meta-analysis was published regarding the different modalities and models done for type 1 and type 2. I will give in shortly some of these models. The treat model, a telemedicine for reach, education, access, and treatment model. In this model, the goal of this project was to assess the team-based and also the decision-making for the patients and the healthcare professional for the treatment, enhancing the patient understanding of the key outcomes of the A1C, enhancing the understanding of different providers in the treat models. And here, number one, the phase one is education of the patient, the healthcare provider, engagement, behavioral changes, and personal endorsement. The patient here is having a team. The team consists of his doctor, and then an educator nurse, which is always on the side of the patient, and then the endocrinologist. And their slogan was, together, everyone achieves more. And what happens in this model, the patient will have different modalities. He will give them these flyers to tell him what about the A1C, what's meant by getting diabetic complication, what does A1C number means, what is the benefit of getting a lower A1C, and then the patient will have daily health sessions, personalized intervention, targeted education, and different coaching for the patient. Here in rural area, this model was invented for patients living in the rural area. Firstly, what happens? His local primary care provider, he will talk with the patient, he will take his information, and then together with the nurse education, you have also appointments, virtual appointments with the nurse educator, and he will provide him with the self-management education. All this information will be forward to the endocrinologist, who will change the treatment plan for his patient. And then regarding the outcome, after 12 months, the A1C was significantly reduced. The consumption of high-fat food was significantly reduced. What about other model, the Mississippi model? It was a longitudinal study, also in patients with underserved area, a telemedicine for 12 months period, a total of 171 patients with A1C was more than 7%. And then there was significant difference regarding the A1C from 3 months, 6 months, 9 months, and 12 months. Also, there was significant difference in the lipid profile. Mississippi here, as I said, the A1C was dropped to 1.7%. There was compliance to medication because the patient was all the time virtually with his doctor, with his nurse, and they were, the retinopathy found in 9 patients. Weight loss was found 71 pounds, and miles were saved because the patient, he was having virtual meetings. And the patient feedback, they were very satisfied, and they strongly agree that they were very satisfied with this model. Another model is Project ECHO. It's active in 4 countries. They even have their network, the ECHO Diabetes Action Network. How does the ECHO program works? The ECHO program, the primary care provider deliver the care to type 1 diabetes and type 2 diabetic patients, real-time provider assistance and challenges, medical decision and making issues, healthcare navigation through the support of multidisciplinary team. Also, all these models, they are having the same, it's a little bit the same team caring for the patient, and the results are a little bit the same, mainly the better outcome. What about the Jocelyn Home model? The patient here built their team. It's a little bit different from the other models because here the patient is having different names for his doctor, for his nurses, for his care professional endocrinologist. He can build his team. Meanwhile, the patient can change any member of his own healthcare circle at any time. The patient will have a box containing the weight scale, the blood pressure cuff, cellular glucose meter with unlimited strips. The Jocelyn Home model consists of 5 new pillars for diabetes care. Number 1, it was short visits. Why? Because the patient, before the virtual meeting, he enters a virtual room where he can answer many questions regarding his blood sugar, regarding his medications, regarding the times of hypoglycemia, the times of hyperglycemia. And that's why the visit will be short, because when he meets with his endocrinologist, all the data is present with the endocrinologist. There is frequent visits. Why? The patient now is having frequent visits with his healthcare provider. And then there is 2-way scheduling. He can reschedule the doctor, and even the patient can reschedule the meeting. The focused documentation of the patients, and the billing, it was something important for the patients. Recommendation of all these studies, they showed that there was improvement in self-management in underdeserved community, grade B. It facilitated consultation with the specialized team as a part of a scheduled care model, grade A. It improved the clinical outcome of type 2 diabetes, including the decrease in A1C. It was grade A. It improved the glycemic control and consequently the cardiovascular risk factor for type 1 and type 2. Regarding the use of telemedicine during the COVID pandemic, COVID pandemic represented the unpredicted challenge to all the healthcare services. And though this driving force, the medical care has migrated from the hospitals to the homes, and thus the telemedicine is considered as an ideal tool to face this emergency. Regarding the COVID era, the market for the telemedicine was very blooming. It was implemented even in emergency service. It was implemented in forward triage. The patient, before going to the hospital, he can have his phone with the emergency doctor, telling him about the complaint, the problem, and then he can have, the doctor beforehand will face the problem. And here is the figure showing that the telemedicine is very blooming in different countries. And then also during the COVID era, the telemedicine is in a little bit primitive source. primitive source using the video calls, the multimodal video calls, the phone calls, the mobile application. However, the real telemedicine, it requires an infrastructure of ICT infrastructure. It was an outpatient consultation regarding also the emergent triage, even hospitalization during the COVID. Different studies during the telemedicine was published. And that's why the telediabetology, there was observation screening for retinopathy screening, food ulcers, risk calculation, documentation of the glucose diaries, continuous glucose monitoring, smart pens, interventions regarding decision making. And in short, what about, in conclusion, telemedicine is something very new. We required it it's required for our diabetic patient. It requires an important infrastructure regarding the hardware, the software, the ICT. It's something like artificial intelligence is very important in this issue. In the future of this telemedicine, regarding the smart pens, the tele-education for the nutrition, as you see here, the market is blooming. The challenges, telemedicine requires the governmental approval, infrastructures, the education of the patient, the education of the caregivers, because using the low-income countries or poor countries, they do not have these infrastructures. Hoping we'll see it in the near future. Thank you so much.